Hi, my name is Julia Lavallee, and I did my presentation on hemophilia and von Willebrand disease. So, hemophilia is an inherited bleeding disorder caused by a deficiency in coagulation factors. So, there is a deficiency in coagulation factor 8 for hemophilia A, a deficiency in coagulation factor 9 for hemophilia B, and a deficiency in coagulation factor 11 for hemophilia C. It is an X-linked recessive disorder, so it occurs mainly in males. However, there are a few cases that have been seen in females, but that is extremely rare. For Von Willebrand disease, it is an inherited bleeding disorder caused by low or dysfunctional von Willebrand factor, which is another coagulation factor. It is the most common inherited bleeding disorder. However, it can be very hard to diagnose because there can be low or dysfunctional levels of this coagulation factor in people that do not have any characteristics of the disease. And there are also 3 different types of the disease. So a risk factor for hemophilia would be males who acquire this inherited disorder. And for von Willebrand, it could be females or males who acquire this inherited disorder. And the disorder follows an autosomal dominant and autosomal recessive transmission pattern. For maternal consequences, there are bleeding, postpartum hemorrhage, and anemia. The fetal consequences includes cephalohematoma during delivery, bleeding during delivery, fetal anemia, and internal bleeding. Subjective data associated with hemophilia would be patients complaining of easy bruising, easy bleeding, frequent goose eggs in children, so they bump their head and get a big bump on their head, irritability in infants, joint pain, and fatigue. Subjective data associated with von Willebrand's disease include easy bruising, easy bleeding, oral bleeding, heavy menses, abdominal pain, and fatigue. Objective data for hemophilia would be joint bleeds, muscular bleeds, GI bleeds, and a prolonged APTT. And for von Willebrand's disease, it would be GI bleeds, postpartum bleeding, thrombocytopenia, microcytic anemia, and a prolonged APTT. Differential diagnoses for both hemophilia and von Willebrand disease include Ehlers-Danlos syndrome, disseminated intravascular coagulation, or DIC, and vitamin K deficiency. Diagnostic testing specific to hemophilia would include screening tests looking at the PT, APTT, TT, or the thrombin time, and the platelet counts. You would also look at the factor activity levels, so looking at coagulation factor 8, 9, and 11. Those levels would be 40% or more below the normal level. And then doing genetic testing, so looking at carrier detection, which is the most preferred method because it establishes carrier status and creates a family history of the disease, so diagnosis can be a lot more straightforward. Diagnostic testing specific to von Willebrand disease would be a CBC and coagulation studies, so looking at levels that would suggest thrombocytopenia and microcytic anemia, and then also looking at the APTT. You can also test for the von Willebrand factor. There are 3 screening tests to assess the quantity and the function of this factor. Those are the von Willebrand factor antigen test, the platelet-dependent von Willebrand factor activity, and also the factor VIII activity. You can also look at the von Willebrand factor propeptide, which is a specialized test that detects the protein sequence when this factor is synthesized at the cellular level. And then also doing genetic testing. It's not usually indicated, but it can help determine the type, since there are a few different types. So treatment for hemophilia would be clotting factor replacement therapy injections that can be used as prophylactic treatment that the patient would receive throughout their lifetime. Pain management, such as acetaminophen, can be used because some people can experience pain with hemophilia. Also physical therapy for joint protection. Von Willebrand disease, the treatment is for severe life-threatening bleeding. You can use von Willebrand factor concentrates. You can use desmopressin. That has been seen for minor cases of the disease. Desmopressin releases endogenous von Willebrand factor, so that can help, again, for just minor cases. And then antifibrinolytic therapy, like TXA, can help with heavy menses or postpartum bleeds. So for education and follow-up, reproductive counseling and testing can be done during the preconception phase for those who know that they are carrier disease, so they can be more on top of the treatment of both the mom and fetus during pregnancy. Doing prenatal evaluation, so an ultrasound to determine the sex of the baby for hemophilia only, to know if it's a male and if they are at risk for developing the disease. Talking with your provider about the method of delivery. Both vaginal and C-section pose a risk of bleeding, and there is a risk for the fetus to bleed during delivery, so it's kind of just up to the patient and the provider to decide what method works best for them. And then hematology would, the patient would see hematology when diagnosed with this disease, and they would oversee the management of the disease and any treatments that they would receive.